This is the Physical Activity Researcher Podcast, a podcast for researchers of sedentary behavior, physical activity, and sports. Join for a relaxed dialogue about research design, practicalities, and, well, anything related to research. Learn from your fellow researchers useful and relevant information that does not fit into formal content and limited space of scientific publications. And here is your host, researcher and entrepreneur, Ollie Tikkanen.
Welcome everyone. We are going to have a special episode today. We will be discussing of ways to self-regulate physical activity and other health behaviors to maximize well-being during and beyond the coronavirus crisis. Our today's guest is Professor in Health Services Research in Plymouth University. He has conducted laboratory studies, randomized controlled trials, systematic reviews, meta-analysis, and qualitative research. He has been founding co-editor of Mental Health and Physical Activity Journal. Ladies and gentlemen, please welcome our guest, Professor Adrian Taylor. So, what kind of research is keeping you busy at the moment?
I've been involved in work on physical activity and mental health for much of my career, over 30 years. More recently, I've been working in a medical school for the last 6 years, running some large trials concerned with the effects of physical activity on well-being, on physical and mental health through exercise referral schemes with a prescription by GPs. And one of the common themes all the way through my career has been looking at how increasing physical activity can be used to help people with multiple chronic conditions and addictions. So in particular, we've been publishing work on the effects of exercise on helping people reduce their smoking or give up smoking, on alcohol, and in terms of compulsive eating or snacking. So the role of acute and chronic exercise on self-regulating other health behaviours. So running big trials is really takes it out of you. I work with a clinical trials unit in the UK. I've had a lot of funding from our National Institute of Health Research, and these trials last for 3 or 4 years. I'm delighted that the most recent one that we have just finished, coming towards the end, has completed data collection for 917 people who were recruited with a 9-month follow-up. And those are smokers who don't want to quit, but do want to reduce. And we aim to provide behavioural support with physical activity to help manage smoking, cravings, weight gain from cessation, and so on. But I'm delighted to say, before everything here with the coronavirus is shut down, we just completed our primary outcome follow-up at 9 months. There are many other trials that are going on that are just being put on hold, and that makes it really, really difficult for when you've recruited people some time ago, they don't complete their follow-ups and so on. So I'm pleased that this particular study has got the data in the bag, if you like. But I can talk a little bit about the interventions that we've been offering to people in that context. So I first got interested in the work around physical activity and other health behaviours through somebody called Roy Shepherd, who's very well known when I was a student at the University of Toronto. He wrote a paper on the associations between different health behaviours, and sure enough, people who are more active tend to smoke less, tend to drink less, unless they're in certain sports, and you can guess which sports those are. In the past, sort of rugby and so on, more sociable sports. But then the natural question comes out of that is, well, does increases in physical activity actually help people deal with a craving or an addiction to substances like smoking, alcohol? And now we're getting papers through in the journal that I founded 12 years ago, co-founded, on internet addiction. I can't imagine through the coronavirus just how much people will become more addicted to the internet, but it's a phenomenon that's sweeping through countries like Korea, Southeast Asia, online gambling and betting. These are becoming huge issues. So how does physical activity impact? Does it have common mechanisms on the way in which people take on other behaviours? Self-regulating, does it help people self-regulate, self-control those impulsive or dysregulated behaviours? So that's been a really strong theme of my work for a good long 20 years or so, leading up to the culmination of my career, probably this £1.8 million trial that we're funded by the National Institute of Health Research here in the UK to look at providing support for increasing physical activity at the same time as smoking reduction for people who don't want to quit but do want to reduce their smoking, at least in the immediate future, with the main outcomes of actually the number of people in each arm of the trial who actually quit. But I've done an awful lot in laboratory level work. So previously, before I was in the medical school in Plymouth receiving some of this funding, I worked at Exeter University, where I had many more master's, PhD students working on acute exercise effects on mood and affect, but also cravings and measures of reward and pleasure, if you like, down to the level of looking at functional magnetic imagery with people put into a brain scanner, to look at how they respond to pictures of cigarettes or neutral images after exercise or after no exercise. And we did a number of those studies looking at attentional bias to cigarette cues and alcohol cues, chocolate cues, and the sort of drawing on some of the psychological theories about addiction and how we self-regulate and manage cravings and urges, neurologically and physiologically as well as psychologically. So it's been great to be able to translate a lot of that work into running an actual trial with real people in community settings and recruiting them through our primary care settings.
Yeah. So what do you see as the most interesting findings from all these trials related to self-regulation and physical activity?
Well, I think if we go back 10 years ago, psychologists were very clear that if you try and tackle one behavior, you should stick with just focusing on that one behavior and not try to take on two behavior changes. I think we're now very clear that isn't necessarily the case. So the risk was that you ended up failing in all the behavior changes, and that's not the case. So we have people who try to give up smoking with physical activity, and they certainly don't show any worse attempts at quitting smoking or reducing smoking. If anything, it's more favourable. And we have a number of theories about how that might be. So our acute work with physical activity unquestionably showed through 20 different studies or more that acute exercise reduces cravings and the urge to smoke. And those effects are evident from both moderate and vigorous exercise. So the good news there is that you don't have to do vigorous exercise. You could do brisk walking, and that appears to have an effect from just 5-minute bouts that last for 5 minutes, and longer periods of exercise might last for as much as half an hour to an hour. So helping people understand, or working with people rather than telling them these sorts of ideas, asking them to reflect on, can you think of a period of time when you haven't smoked as much? And they may reflect that they were walking in the park for 2 or 3 hours with the kids and doing something that they enjoyed that provided a distraction. It elevated their mood. It took their mind off the stress that they were experiencing, and that therefore smoking patterns, behaviour actually changed as a result of that. So that's roughly some of the summary things that we've done, and we're cited by the US Surgeon General report on tobacco control, and in various guidelines around the world, in Australia and Canada, on ways of helping people reduce their smoking. So those are some big things, and when you run a trial, you run the risk of not showing any effects, and we just have to wait sometimes 3, 4, 5 years before we actually get the results. And we're sort of in that stage at the moment with some of these trials that I've just been mentioning.
And you said you have a number of theories how this could work, that you can actually change more than one behavior at the time. Would you like to tell more about the theories?
Well, I think there's certainly the element of distraction, and we can actually test that, and some studies have done that with a control group that involves distraction, and you still see the same sort of effects consistently. It could be through improving mood. So we know that people tend to smoke more when their mood is lower, when they're under stress, for relief of boredom, for improving, elevating positive affective state. So we know that when people, physical activity can replace those urges to get into those affective states that they seek from smoking, or indeed eating chocolate, or indeed drinking alcohol. So that's one approach. Another mechanism might be that people end up going and socializing with different people. So instead of going to the pub after work, if you choose to have a gym membership, or you go with friends and do a walk, and do something that replaces the triggers that would normally contribute to that other unhealthy behavior, that might be a very reasonable mechanism to suggest.
Yeah, so you said that there's a distraction, mood, and socializing with different people. Do you see that some of them are more influenced in different cases, like, for example, in smoking versus alcohol use?
Yeah, I think we when we devise an intervention, we make it as generalizable as possible. So we work with individuals. We never prescribe anything. We never prescribe a physical activity. We never prescribe a rate of reduction in smoking. We never talk about having to quit and putting pressure on people. We draw on their own experiences and situations. So, for example, in a book chapter we wrote, and in a final report, we were working with somebody who smoked. He told us he smoked about 20 a day, and then the following week, when we had a counselling session, he realised that he came back and said, well, actually, I didn't count all the cigarettes that I was smoking while I was watching television, and it's actually about 40 cigarettes I smoke a day. So he was not regulating a behaviour, and by engaging him in self-reflection, self-monitoring, he was able to think about, well, actually, I was doing these behaviours automatically. So putting in a self-regulation mechanism was allowing him to think about it. So he wasn't interested in the physical activity at the start. He was more interested in, well, I can manage my smoking reduction. I can control that by looking at 5 cigarettes less a day or a week, and then a reduction, and I've got complete control over that process. Nobody's telling me what to do. And then a few weeks later, he came back to us and said, well, you know what, I'm actually feeling less breathless by going up the stairs. And that's prompted me to think, well, actually, one of the things I've always wanted to do was go back to using the gym and getting into an exercise regime. And so that thought pattern has triggered itself from his own self-reflection rather than any prescription on our part. So what our interventions tend to do is very much help people gain a sense of control over behavior change rather than being prescriptive. And particularly, when people are going through high and low mood states, that's that they can monitor those moods. They can associate wanting to smoke more with low mood, with being bored, with the affective situations that drive behaviours. And so this then became the point for this particular person was that he decided when he started going to the gym, he thought, well, this is crazy. I'm undermining all the benefits from doing the exercise. And he just quit. So from being somebody who wasn't interested in quitting, we shifted somebody to the point of quitting and taking ownership of that quit attempt. For other people, it might be that they've experienced attempts to quit. Most smokers are people who've attempted to quit in the past and had struggles with that. And they may have gained weight, and the average weight gain might be from 4 to 7 kilograms a year in the first year after quitting. And that causes a relapse back to smoking, and they've struggled with that weight gain in terms of their personal identity, self-esteem. And so by taking on physical activity at the same time, that's potentially adds a way, and it is actually one of the most effective ways of managing that weight gain. So people find ways of doing this in their own way, and we never make an assumption about prescription. We work with people.
Mm.
So one of the stop me if I'm talking for too long, but
no, it's very, very interesting. It's no need to stop. I think it's very interesting that, like you explained, that there's different kind of stories, and that the weight gain is often the problem when you stop smoking. That it leads to a different identity or identity crisis, and then it's easier to start smoking. How often do you see this kind of pattern?
I think it's people who have experienced it. So we may start a session which is underpinned with self-determination theory, which I can talk a little bit more about before, but also motivational interviewing principles. So we start by asking somebody possibly, so tell me a little bit about, your smoking over the years. Have you ever tried to reduce before? What brings you here to this session today? And that gets them engaged. That gets us an opportunity to express empathy and understanding of their situation. So they may raise it with themselves that, I've tried many times. I've tended to put on weight and I've gone back to smoking, or I've started interacting again with other people and they put pressure on me to start smoking because of the places I go to. And so on. And so we may just say, I've just wondered if you've ever sort of tried physical activity. And, that opens the door for another conversation and a distraction from that. And some of what we do in our setting up developing interventions is we do an awful lot of what we call public patient involvement. And in an earlier piece of work that we did called Walk to Quit, went in and sat in stop smoking service clinics with group-based format. There'd be a table of 20 people who all stopped on a certain date, turned in their cigarettes, their ashtrays, their lighter, and they all were in this together. And they received behavioural support from a stop smoking service advisor. We sat in, listened and watched. And conversations, as you might have expected, never came up about physical activity. People were there to quit smoking. Prior to one of the sessions, we overheard one of the ladies talk about having joined a gym. So instead of going round the circle randomly, just asking people to reflect on how it had been for the past week, what cravings they've had, how they managed that. We started the conversation with this particular lady. Turned out a friend next to her had also gone, and they talked about their physical activity and how it was helping them. And believe it or not, the entire room talked about how physical activity could or couldn't help them with their smoking. So the conversation was not about how hard it had been dealing with cravings. It was about a distraction about physical activity. And so we tried to embed that into our interventions. So we get people to think about, experiences. When have you gone without a cigarette for a while? Was it, were you being physically active at the time? What have you tried? What could you learn from other people? And we use hypothetical examples. So we say, I was just talking to somebody the other day, in this job that I've got supporting people, and they were saying, if I did physical activity, it helped me reduce my weight, and it also really helped me prevent boredom and some of the cravings. So, and we say, well, how do you feel about that? About this story that somebody else has told us. So using those sorts of opportunities for people to be prompted and reflected in a non-directive way, we find goes down very well with participants in our trials.
This podcast is sponsored by Fibion, a research device that has been shown to be valid in tracking sitting, standing, physical activity and energy expenditure. Furthermore, Fibion has been shown to be valid categorizing physical activity into light, moderate and vigorous intensity. In addition to scientific accuracy, Fibion provides automatically produced and easy-to-understand reports for research participants. Get scientific validation and learn more about Fibion at fibion.com/research.
Yeah, and do you usually actually get people to do the physical activity with this kind of prompting, or do you need to do more actions to actually get them to start physical activity?
So we just updated our Cochrane review on exercise and smoking cessation in December. Michael Usher and I have been writing that for 20 years, updating it regularly. And most of the interventions have been around prescribed exercise. So Best Marcus in the US it led one of the only trials really that has provided us with good evidence that exercise can help manage smoking and help quit rates. And they were very prescriptive. So they got a group of smokers who were very committed, very enthusiastic, probably in a university setting, quite well educated. And sure enough, engaged in this compared with a control group who didn't get the prescribed 2 or 3 exercise sessions a week. The exercise showed a benefit. As time has passed, we've realized that exercise sessions, when you try and put them on for smokers, aren't particularly well attended. It's not something that we know that people who smoke are less active, and as time has gone by, smokers have become more hardened as the prevalence rate has reduced. Fewer and fewer people smoking. Those smokers who do smoke are quite resistant, becoming more resistant to change. So we have to develop new ways of approaching this rather than just offering a prescribed 2 or 3 sessions of exercise in alone or in group format. And so we've been trying to look at more efficacy rather than effectiveness rather than efficacy studies. So efficacy studies would focus on a specific dose. Effectiveness would focus on, if you were to offer this behavioral support in the community to people who want to reduce but don't want to quit, what would be the consequences? And so it's more tailoring it to using motivational interviewing, client-centered approaches that engage. If people don't come back after the first session, then there's no chance of change. But if we develop empathy in the first session, we are seeing that we're engaging people with up to 5-6 sessions on average across 450 people to come back, talk to us on the phone, talk to us face to face, and look at ways of behaviour change using, some of the theories. So I spoke before about self-determination theory, and this fit really well with motivational interviewing. So we've broken self-determination theory into the 3 C's. So when we work with practitioners, and we've done this, we did this first of all with a trial on exercise in primary care for patients with depression. And we trained practitioners to think about the 3 C's. Think about the 3 C's in terms of that immediate session that you've got with a participant in front of you, and you've got the period of time before you meet again. So we ask practitioners to think about the first C might be, have you undermined their sense of competence or confidence? So I could easily undermine the sense of confidence if I said, really, you should be trying to achieve 10,000 steps, or you should be doing 30 minutes a day, most days of the week, and it should be a moderate vigorous level. And I find it, during a typical workday, very, very difficult to achieve 10,000 steps. I don't know if you do. I think many people struggle. So if you set a government target of that, and it's way out of the reach of most people, then you're setting people up for failure. You're undermining their sense of confidence. If you set client-centered goals, you work with somebody to set what might be reasonable, to be achievable, SMART goals, then you build up and you work and you don't experience failure so much, whether it's just the physical activity or the smoking or whatever. So we built that in to also get people to, in that individual session, also go away and think about, between now and the next session when we meet, how will you feel more competent? So yes, set some goals, achieve those goals, you'll feel more competent. But also trying to avoid barriers, overcome barriers, think about barriers, planning what-if scenarios and so on. Let's move on to the second C, sense of control. So are we undermining people's sense of control by being prescriptive? I think we are very often. What happens when, if we were to give somebody a prescription right now, then they're not controlling it. The prescription is, I think you ought to do 3 sessions a week to get your fitness level up. But, we're taking control away from people by being prescriptive. How we exercise is really, where we exercise. There are many opportunities for giving people a sense of control over the decisions of how quickly to increase that progression of exercise, where to do it, who with, and how intense, and where it fits into their life. So it may be active commuting, it may be walking with the family, maybe pushing a pram briskly, giving people the opportunity to identify things that fit in with their life gives them a sense of control. And we try and have a check after each session that a practitioner has worked with somebody, in what ways, we ask them to write down, in what ways have you given people a sense of control. And the third C that we talk about is connecting. And that is about relatedness. If you go back to self-determination theory, it's about doing the things that you can enjoy and share with other people. So I listened to Stuart Biddle's podcast, and we are in this incredible, difficult situation with Corona where we're self-isolating. For some people, that is living at home by themselves. and a prescription that it would be a good idea if you did 3 sessions of exercise a week, or if you did 30 minutes a day in your front room. I've always said to students, if you were given an exercise bike to sit in the front room by yourself and do 30 minutes exercise a week without being able to feel more confident, without connecting with other people, without feeling in control, it's just a prescription. I don't think most people would last very long doing that. So we're trying to look at ways of sustainable physical activity, and self-determination theory is nothing new for motivating people to be physically active. But we've just broken it down into the 3 C's, which our practitioners can remember, in order to check that they're doing the right thing with people. They're not removing a sense of competence. They're not reducing a sense of control. They're not reducing a sense of connectedness and companionship. And so many of the things that Stuart was talking about in the other podcast was about connecting with other people through the internet, through exercise classes, competing even with other people. If you've got a bicycle with connected to the internet, you can, see how you're doing with other people. But it's a unique time where we can't use Strava outside, and we can't, we can't connect with people in the way that I do. I do something called Hash House Harriers, and I run with running groups, and I orienteer, and we meet and we chat, and so on. And it's just taken away from us all, the social element. But finding ways to connect with people through physical activity is a way that not only is going to help you be more sustainable over the months to come in your behavior, but it's also going to help you feel better about yourself, about your well-being. And so, people often ask me, well, how much exercise do I need to do for feeling good, for mental health? The answer is always as much as you feel you can do in a way that will help you feel better, and you will continue to do it. So, there's no fixed dose, I don't think. I often say that just doing exercise by itself has some physiological benefits on our mood. And we can all, recall endorphins and stuff like that. But if it's not sustainable, if it doesn't give you a sense of control and companionship and a sense of competence by improving in some way, then it's unlikely to have as much of a benefit as just doing it by itself.
Very, very interesting points.
This podcast is sponsored by Fibion. Fibion is an accurate sitting and physical activity tracking device and analysis platform. It is a great tool for projects that aim for behaviour change in sedentary behaviour and incidental physical activity. Fibion provides easy-to-understand PDF and web browser reports for participants. Other features include comparisons to recommendations, linking results to health risks, achievement cards, and interactive goal-setting tool. In addition, Fibion provides an API that allows for easy integration to other systems and applications. Learn more about Fibion at fibion.com/research. Fibion, from researchers to researchers.
Do you think we should really avoid prescribing anything? And do you think even the physical activity recommendations go wrong, that they are really prescriptive?
Yeah, we've talked within the editorial group on mental health and physical activity, this journal, about whether there can be a separate prescription for mental health, because the prescription is very much based on cardiovascular fitness. And we used to think many of the earlier studies in America, where they started doing this work before, was very much a prescriptive, if we test the effects of 3 sessions of exercise on mood. Physiologists were adding to the outcomes of interest instead of just looking at effects on weight, effects on blood pressure, effects on cardiovascular fitness, people started to put in a few measures of mood and affect. And, this was going back 40 years when the first book on physical activity and how you feel was written. So I think the dose response question around physical activity and mood and affect and mental health is much more, we need to add the quality of the experience as much as the quantity. So a simple prescription isn't something that might necessarily be sustainable. It might be for 10 weeks if you're in an exercise program. I've spent quite a lot of my career looking at the effects of GP doctor exercise referral programs for people with chronic conditions, where a patient is referred into a gym. And the earlier schemes back in the early 90s were very much about following a prescription. And I think the field has moved on now to helping people find ways to accumulate that amount of physical activity, or their sustainable amount of physical activity for themselves and with who they want, in a way that's more sustainable. So walking with groups outside might be more suitable than sitting in a gym. So I think, yes, prescription for exercise and mental health is more difficult to be prescriptive than it is for than other physical health problems. In the UK, we have guidelines on exercise and depression, and those guidelines are based on the research that's being done. And sure enough, if we look back over the last 30 years, the research that has been done was mainly around prescribed doses. And there was an assumption that if you got fitter, you reduced your depression. And we certainly know now that that's not the case, that if you have a quality experience, you can get just as much benefit. If you quality experience in terms of doing it with other people, sharing the experience in terms of being in blue space and green space, you can enhance the quality of the experience rather than just sitting in your own room, sort of pedaling away on a bicycle.
These are really, really good points. Yeah, I'm really excited to hear these. That, yeah, I think the recommendations now are really medical, physiological, and they don't take care the quality of experience at all. Or maybe there's a little bit saying that what you enjoy is good. But I think this would also help to people to adhere and do better. So I think it's a really, really good idea to try to bring more the quality in addition to quantity.
Yeah. So just turning to well-being, Ollie. So in the UK, the government commissioned a report on ways to well-being. And they did a review of literature and they came up with 5 ways to well-being, because governments are really keen that their populations increase their sense of well-being. I think the current coronavirus is an incredibly natural experiment, and we will in the future look back at how self-isolation of a third of the world's population has impacted on people's sense of well-being, if not their sense of more serious mental health problems. But this report from about 10 years ago now was called the Foresight Report, identified 5 key ways to well-being. And we've repackaged these again to help train practitioners who we were working with offenders under community supervision in the community, who are really come from really disadvantaged backgrounds. And the primary outcome of our study, with 120 people, was an intervention to provide improvements in well-being, primary outcome was Warwick Edinburgh Mental Wellbeing Scale. And typically offenders and people living in prison have much lower scores of well-being. They're more like under 40, whereas the normal population is 50 to 55. And so improving well-being, we know, is actually a key to how people behave. So higher levels of well-being associated with lower alcohol intake, lower smoking, more physical activity, and better self-regulation. Lower levels of well-being are associated with worse behaviours, health behaviours, because people turn to self-medication. And so we don't know at the moment. It will be interesting to see what the consequences of self-isolation will be, because it may well impact on increases in alcohol consumption, more online gaming, and getting your thrills, if you like, from other behaviours, pornography, all sorts of self-rewarding behaviours. But one of the 5 ways to well-being, which was in this government report, was about, we've called them CLANG, C-L-A-N-G. So C stands for connecting. We know that if you connect with people, improves well-being. If you're well connected, you've got good social support networks. And at this current time, most of us are talking about connecting with people who live in isolation through internet, through however we can do that, telephone and so on. L for learning. So people who engage in learning tend to have better well-being. By learning, we can get involved in courses, in training, feeling more competent about our knowledge, taking an interest in a variety of things which adds to our ability to understand the world. So many people are learning about viruses, about the spread of viruses, about epidemiology, just by listening to the news. We're going through a period of unprecedented interest in these things. So that actually possibly helps people feel better. Activity, CLANG, C-L-A, activity. So physical activity is in there. It improves people's sense of worth, sense of well-being. Notice, N. So noticing things, when people notice changes in themselves, they take an interest, they experiment, they change, notice the environment, the leaves starting to come out in spring, they notice weight loss, they notice dietary change and patterns through self-monitoring. They notice, if you wear an accelerometer or a pedometer, you start to notice that you've had an inactive day, you notice that you've had a more active day, how many steps you've achieved. This is all helping you gain a sense of self-experiment, if you like, a sense of well-being. And G for giving, being altruistic. So people have a higher sense of well-being when they give, when they're altruistic. So you could do a sponsored run. You could sponsor somebody to be physically active. You could volunteer in a sports group. You could become a coach and volunteer. You could do all sorts of ways of helping an older person get out for a walk. Our current guidelines, as they are in other countries in self-isolation, are, you should get out and do 1 exercise session a day. That's what you're allowed to do. So I know you're not supposed to get in contact with people, but, there are people in your own family who you can help through physical activity. So one of the things we focused on in this intervention with offenders was changing a number of health behaviours at the same time, including physical activity. And we cross-tab the CLANG, the connect, the learn, the activity, the notice, and the giving against a number of behaviours. So if somebody said, in this intervention, we asked them, so are you interested in any of these lifestyle changes? And they may say, diet. I'm interested in, I know I've got a terrible diet. I should change. So we think about, okay, so connecting. Is there anybody who's got a better diet? Could you connect in the internet about diets, better support by better diet? Are there cooking groups? Learning. Could you find how many calories there are in a product and learn about food and energy intake, etc.? Is there physical activity that you could do to help regulate your chocolate consumption? Noticing weight gain, assessing, self-monitoring, giving. Is there a way that you could provide food for other people, homeless people, through diet and nutrition and so on? And in those ways, you've actually ticked some boxes about improving your own sense of well-being. And you could do the same thing with physical activity. So it's not just about doing the physical activity. It's about connecting. It's about learning. It's about noticing changes in yourself and in the environment, getting out into blue and green space, and about being altruistic and giving by being physically active. So we've put together in some of these interventions some really logical things, but try to break them down into ways that practitioners can work with on a one-to-one basis.
Yeah, it all makes really sense. Yeah, please go on.
So in the situation we find ourselves, we could be carers, we could be responsible for an older person who's in confinement because they're vulnerable. We could have kids in our own house, in our own household, and we're all self-isolating. So the practitioners we work with, who are trained to check these things about Clang and about the 3 C's, if you're a parent, you could try and check these things off with your kids. Are you helping your kids through whatever physical activity you do to connect with other kids? Are you helping them to learn about their bodies? Are you helping to notice the changes that they experience? So if they do an exercise regime, they do an exercise program, they take their heart rate, they're noticing what their heart rate response is to that exercise, and maybe that changes over the next 3 months. And you could get them to write that down and notice the changes. You could do a sponsored exercise thing within the household, or in the exercise sessions where you go out as a family. You could say, if I achieve so many steps, I'm going to give this amount of money to a charity. So that all enhances the quality of the experience rather than just the quantity. So I think, a lot to reflect on there, but it's a little bit more structured because we've had to develop these interventions in a way that practitioners could be trained, and in a way that we can check that the practitioners are doing what we are asking them to do. In other words, moving on to what we call intervention fidelity. But I think there are some lessons to be learned in the current situation that we're all in about physical activity not just being a dose, but being about the quality of the experience, whatever situation we're in.
Yes, and I think it all makes a lot of sense with the Clang. And do you have you written a guide for practitioners how to use and utilize this, or where they can learn more about this?
Okay, so we've published a protocol paper on our Strengthen study, which was the one with offenders. We're just about to submit a protocol paper which again describes the intervention content for our smoking reduction and physical activity trial, which I was talking about before, this £1.8 million trial with 915 smokers who don't want to quit but do want to reduce. So the intervention is described within those papers. So the strengthened paper has certainly been published. The full report has been published, which again looks at intervention fidelity delivered by health trainers. And so that I can send you some links to those papers.
This podcast is sponsored by Fibion.
My name is Dr. Paul Batman, and I'd like to just say a few words about Fibion. I've used it a number of times on different projects that I've been involved in and find that it's incredibly reliable, very valid, and incredibly sturdy. I love the graphics that come with it. It really is very clear and can easily see the active and inactive periods as well. So I'd certainly recommend Fibion to anyone that's interested in finding out more about sedentary behaviour, particularly the concept of sitting and how we can possibly break it up with some really good, valid information.
And how do you see this corona situation, that there's social isolation and so on? How would you advise people to use these parts of Clang to be able to actually do physical activity now in these special times?
Yeah, so I think, just going back to the quality of experience, so improving well-being, if that's, keeping fit, yeah, physical health is really important. But how to maximise, if you are able to keep active, going out, doing one exercise session a day, or you're able to do exercise, as Stuart Biddle was talking about, online with dance classes and other groups online. Can you do those with other people? Can you share the experience, either before or after it, or within your own household, with the kids, with an older family member, husband, wife, within your household? You're connecting with people, and you're actually, some families may never have exercised before together. So it's a remarkable opportunity to actually do things together. I looked out my window yesterday and I saw a father and son doing some DIY work. The son must have been about 7 years old, but he's pushing the wheelbarrow with some bricks in his back garden. They'd probably never done that before. I looked again, I was out for a run a couple of days ago, and a 6-year-old girl was painting the wall outside their house where they park the car. And the parents have got them involved in some physical activity related to DIY. Those people, the parent, child, are connecting in a way they've never connected before. So phenomenal opportunities if you think about how you can, do DIY gardening with kids. Learning, if you are fortunate to have a garden, it's a great time in spring to start planting some stuff, see the seeds grow, learn about, how far to plant them, sustainable, being sustainable in our food and diet. Great way to learn about, the natural environment and seasons. Noticing these things, self-monitoring your activity level. So try experimenting. What's the least number of steps you can do in a day? I could probably do no more than 1,000 steps, just going up and down the steps. On a really bad day, if I was at work in my office, I could do 1,000 steps. So experiment, see what's the minimum number of steps that you could do in a day. And then think about, what do you normally do? Monitor, self-monitor. So notice these things. What influences you doing more? What influences you doing less? So noticing this. And if you are allowed one exercise session, I have to tell you a joke that the police here in my part of the UK have been inundated by nosy neighbours phoning the police to say that they're sure some people have been going out for 2 exercise sessions a day. How crazy is that?
Yeah.
So you are allowed an exercise session a day to go out and do that. You're allowed to go out and get groceries, but you're not allowed to drive to your exercise session. So you can go out, but you can, on that walk, on that cycle, on that run, you can notice things that you've never noticed before about your body, about how it responds to hills, about how it responds. Stop, look around you, notice nature, notice, as things grow, and notice the deer, notice, frogs, notice things, become more aware of your environment. And then lastly, giving. As I said, you can get involved in sponsorship. There was a guy on the television yesterday in the UK who had set up a running route around his garden, and he did something like 1,200 laps of his garden to do a marathon. And he donated money to charity. So he felt even more good about doing the exercise because he was giving as well. One of the 5 ways to well-being. So there are creative ways to experiment in this time of real uncertainty and, really unusual about what enhances the experience of being physically active.
Yeah, very, very good points. So you brought up many positive sides that you also see in this situation. How do you see the negative sides with mental health and alcohol use and other things?
Yeah, so I think there's a danger of generating boredom. There's a danger of generating apathy and a sense of loss of control. If you are a regular exerciser, maybe there's a danger of feeling less competent. Maybe you were planning to do the London Marathon next weekend and all your training has gone out of the window in the space of 2 weeks. Maybe you are obviously isolated and your running group has disbanded and you can't mix with the people. My running group, the Hash House Harriers, we always go to the pub after an hour of exercise in the natural environment and we socialise, and that's gone out of the window. So maybe those mood states of low positive affect, of boredom, and low well-being push you into wanting to self-medicate with alcohol and smoking and snacking. So it will remain to be seen whether people eat more and snack more and use comfort foods such as crisps, chocolate, high energy food sources and gain weight, or whether the stress actually, makes them less likely to gain weight, or maybe food shortages make people less likely to lose weight. But we don't know. But normally, low mood is associated with some unhealthy behaviours. But if you feel apathetic and you feel out of control and disconnected, maybe you don't have the same cues and prompts to get out and be physically active, and you can't get turned on, if you like, by sitting on a bicycle by yourself. So maybe that physical activity levels really decline, people gain weight through unhealthy behaviours, and they smoke more. On the other side of things, our public health messaging is coming out with messages like, this is the best time to stop smoking for your own health. If we're in this for the long haul, for 12 months, and you said to somebody with a chronic condition, you could reduce your blood pressure by being physically active one session a week, you could regain control over blood pressure, over weight to some extent. This is an ideal opportunity. You don't have the stress of work. You've got more control over your life. You can work when you can at home. You can do more sociable things with the family. This is an opportunity for me to reduce my chronic conditions that seem to be linked to a higher death rate with the coronavirus. So, if you can take control over your healthy lifestyle and reduce your chronic conditions, reduce your blood pressure, your weight, possibly respiratory problems due to smoking, over the next 6 to 12 months, when this virus might still be around and you haven't yet caught it, but you might catch it, there's a risk here that you could self-manage that risk through a more healthy lifestyle. So there is evidence that I was just reading about that comes through the Centre for Perioperative Medicine, which is a cross-disciplinary medical group who seem to have identified some information from China that says fitter people were 5 times less likely to die having contracted coronavirus.
Interesting.
So that
please
might
go
go
on.
through because they don't have the same chronic conditions. So you may feel a sense of helplessness in all this situation, but there is an opportunity to actually gain a sense of control and a sense of well-being through doing things that you are in control of. And Stuart Biddle was talking about this. Do the things that you're in control of and focus on those rather than focus on the things that you don't have control over.
That makes sense. So this is a very special situation, like you said. Are you planning any data collection to do that we would actually learn more from this situation, from this huge experiment?
I personally won't. I'm now, just since the beginning of February, I've reduced to 2 days a week, and that will allow me to write up the studies I'm involved in. But I'm starting to wind down, if you like, a little bit, and the sort of work that I do, the study is submitted in outline stage. It takes 6 months to get into the full bid stage. It takes another year to get into you've received the funding, you can start, and 4 years perhaps to do the study. So I don't want to be in my 70s when I'm still doing these studies and managing, if another virus comes along, recruitment issues and extensions to contract and all of those sorts of complexities and staffing issues. And so I've probably done my bit. I've got other junior researchers who are, I'm supporting and so on, but I personally am not planning any more studies. But I'm keeping on as editor-in-chief of Mental Health and Physical Activity for the next 2 years. We're trying to redesign the editorial board, bringing in more editorial board associate editors and editorial board members with interests from exercise and alcohol and drug misuse to depression, anxiety, serious mental illness, schizophrenia, bipolar depression, and so on. So, there's a lot still going on. I'm not cutting, I still will be involved for the next 5 years, but it won't be in terms of leading any more big trials, which take a huge amount of personal energy.
I fully understand.
But I think there's huge opportunities. I think that's what you're saying, that to look at. We will have physical activity monitoring systems around the world that will be able to tell us whether people have become more active, less active. There's digital remote sensors around, on people's phones, and Google will be collecting this information on, what happens to people and who are the people who become more active, less active. Are they people with physical activity as a habit? Or are there new people seeing the relevance of physical activity in the current circumstance are making an extra effort because those time barriers have perhaps disappeared. They're not spending 2 hours a day commuting, so they've got more time on their hands to think about buying an exercise bike, buying the right kit, doing things they've always wanted to do, avoiding inactivity. So it's a really interesting time to look at some of these questions. I think, I speak to people in more working, more manual skill jobs who often say to me, all my life is physical activity. I'm very active. I don't have time for that leisure physical activity. And so this is now actually a chance where they have an opportunity to think about leisure physical activity. How can I do that? I've never had the energy to do it with, I'm a window cleaner, I'm a builder, in those things that people do accumulate a lot of physical activity, but they don't do leisure time physical activity, which they have a sense of control over. So now there might be opportunities for people to think about, going for a walk. Where do you go? How far do you walk for? Who do you walk with? And, leisure time in a way that has never been on their radar before.
I really like that you have been able to prod a lot of positive sides also in this situation, and they all make sense. Is there something else you would like to add to this discussion?
No, I was obviously concerned I was going to overlap with Stuart Biddle, having listened to his talk just a couple of days ago. So Stuart and I have worked together for a long time, and socially, and we're well connected and similar interests. He inspired me initially, and no doubt, I've given him some things to think about. So I think I was worried that we would overlap in this podcast, but I think, having said what I've done, I think it is a bit different from what Stuart has said, and it's, possibly adds to the debate and discussion. I think, as parents who are perhaps fulfilling the role of PE teacher at home during this isolation period, you're having to become, role models. You're having to become able to help your children with whatever stage they're at, learning about maths, physics, physical health. And you can do that. You can become a PE teacher. Because, if you approach it right, if you approach it in a way that's not directive, but encouraging, rewarding, that builds the 3 C's, a sense of competence, a sense of control, and relatedness, you're more likely to have engagement with your kids in those types of activities that you've got available. So, the principles we use for training our practitioners, our health trainers, you can take those principles on and work with your children, work with possibly trying to encourage your older relatives who are in social isolation to be more active, to take an interest in exercise opportunities online, or, whether it's lifting up milk bottles, taking an interest in physical health. That's something that you can do in a positive way rather than a directive way. So I think, Ollie, that's probably, I've said quite a lot, and, hopefully that's been of use to listeners.
This podcast is sponsored by Fibion. Get scientific validation and learn more about Fibion at fibion.com/research. The Physical Activity Researcher podcast has created an activity tracker purchase guide for researchers. Get your free copy from the link in the podcast description.
Thank you for listening to the Physical Activity Researcher podcast.